Welcome to this presentation, ACOs, the Future of American Healthcare. I'm Andy Heyer. As you can see from the title of this presentation, there is a question mark in it. And that is because much remains to be seen regarding how common ACOs will become in the American healthcare industry and whether they will ultimately be successful in controlling costs. As an overview to these 4 presentations on ACOs, first, in this presentation, I will provide a brief overview of the problem of high health spending in the U.S. and the development of managed care over the last few decades as a tool to address health costs. In this first presentation, we'll also look at ACOs at a conceptual level and how they were first developed. In the next presentation, I will discuss the creation of the Medicare Shared Savings Program under the Affordable Care Act. We'll also use this as an opportunity to review the administrative rulemaking process and how the government takes something enacted in a statute and creates regulations to implement the program. In the third presentation, we will look at ACOs from the perspective of healthcare providers and what creating an ACO entails and what healthcare providers need to do in order to succeed with an ACO. We will also look at legal issues ACOs may create for providers, including antitrust and healthcare fraud related concerns. Finally, in the fourth presentation, we will look at the future prospects for ACOs in American healthcare, both by looking at the current data on how successful ACOs have been up to this point, as well as some future predictions by experts in the field. As a background, a major aim of accountable care organizations and other value-based payment models currently being developed is to control costs. So it's important to understand some past trends in health spending and some prior models that aimed at controlling costs as well. After the creation of Medicare and Medicaid in 1965 and the rise of private health insurance in the latter half of the 20th century, healthcare costs grew precipitously. At the same time, more technology was being developed and adopted in medical care, further adding to the cost of healthcare. As health science studies students, you should already be familiar with the dramatic rise in health costs over the last few decades. This is a chart put together by the Kaiser Family Foundation based on federal data. I want you to pay particular attention to the changes that occurred between 1960 and 2010 on the left-hand side of this chart. And keep in mind that the dollar amounts are not controlled for inflation, and there was a lot of inflation in the 1970s. So it may be better to pay particular attention to the row towards the bottom that provides the percentage of the total gross domestic product, or GDP, that went to NEH or national health expenditures. And you see this more than doubled between 1960, right here, and 1990. It went from 5% to 12.1%. But then between 1990 to 2000, right here, the share of GDP consisting of health spending went up only 1.3%, which is much less than in prior decades. But then it went up by a whopping 4% between 2000 and 2010, as shown right here, from 3.4% to 17.4%. And these projections here say that the current decade, between 2010 and 2020, the figure will probably go up about 1% total. And there are a lot of factors that have contributed to the growth of health spending over the last few years, but I want to focus on just 2 of those that have been identified as major factors for growth since the 1960s. The first of these is this concept of moral hazard. And this is a term used in economics, and it really has nothing to do with ethics or morality in the context we'll discuss it. Historically, it referred to how having insurance may tempt an honest person to not be as careful. hence the word moral. For example, if you had fire insurance on your home, does this create a temptation for someone to not take as much care to prevent the fire? And an economist by the name of Kenneth Arrow is credited with observing how this concept could apply with health insurance. And he explained moral hazard simply as the effect insurance has on incentives. And back in 1963, he observed, in medical policies, the cost of medical care is not completely determined by the illness suffered by the individual, but depends on the choice of a doctor and his or her willingness to use medical services. It is frequently observed that widespread medical insurance increases the demand for medical care. And so by having medical insurance, And so by having a third-party insurance company pay for services, you will see more health spending. And in the years since 1963, Arrow's observations have been proven with empirical research. But now I want you to think about the part of the quote from Arrow that the cost of medical care partially depends on the choice of the doctor and his or her willingness to use medical services. And this is a concept called supply or provider-driven demand, the second factor I want you to have in mind. Supply-driven demand, or sometimes you will hear it referred to as provider or physician-driven demand, means that providers or physicians determine the amount of care that is delivered. So rather than as in a well-functioning competitive market where demand determines the price and supply, with a third party, like an insurance company paying for services, the supplier is in a position to provide demand by creating more services. So rather than as in a well-functioning competitive market, where demand determines the price and supply, with a third party like an insurance company paying for services, the supplier or the healthcare provider, the physician, is in a position to create demand by prescribing more services. Atul Gawande sums up the role that providers and physicians in particular play in contributing to health spending as follows. Healthcare costs ultimately arise from the accumulation of individual decisions doctors make about which services and treatments to write an order for. The most expensive piece of medical equipment, as the saying goes, is the doctor's pen. And for a variety of reasons, physicians and other providers have incentives to prescribe more treatments, and particularly under a fee-for-service payment model. The training and culture of health practice may favor doing things and doing more things. Physicians have worked very hard in their educations to learn to perform procedures. And for a variety of reasons, physicians and other providers have incentives to prescribe more treatment, particularly if working under a fee-for-service payment model. The training and culture of health practice may favor doing more things. Physicians have worked very hard in their educations to learn to perform procedures. Doing things to heal patients is much of what physicians are trained to do under the medical model. And a potential profit motive is a major concern where you have a fee-for-service system that financially rewards providers for doing more. And there are also malpractice concerns. If the standard of care in a community is to perform a particular test in every instance a patient presents with a given set of symptoms, even if the empirical evidence does not support this practice, a physician could face malpractice lawsuits for failing to follow the community standard of care. And the idea behind so-called conventional insurance is that a physician is trusted to prescribe the care that is reasonable and necessary, and the insurance company will pay a reasonable rate set by the physician without question. So with this type of system, you can see how moral hazard and supply-driven demand can become major concerns. Now here's another chart from the Kaiser Family Foundation illustrating changes in how healthcare was made or healthcare was paid for during the last few decades. To the far right, in 1960, you see that 55.9% of care was paid for out of pocket. Medicare and Medicaid were not created until 1965, and private insurance was not all that common back then. But by 1990, only 22.5% of personal health expenses were paid for out of pocket. And remember, from a few slides back, how precipitously health spending grew during the time frame of 1960 to 1990. So as fewer health expenses were paid for out of pocket, patients or consumers had less reason to worry about the cost of care. So I hope you can see the role that moral hazard has played. Yet despite this issue with moral hazard, nearly all economists will agree that medical care is an insurable risk and that some form of health insurance is a good thing. You may get very sick one year and require lots and lots of expensive care, way more than most people can pay for. But many years, you may not need hardly any medical care at all. This variation in whether an instance will occur or not is the hallmark of the type of thing where insurance has the potential to work very well. But because of moral hazard and provider-driven demand, more health insurance means higher costs. And with this rise in third-party payment and the associated rise in cost, the concept of managed care began to take hold in the 1970s and 1980s. Rather than with conventional health insurance, where the physician prescribes the treatment and the insurance company pays the bill without question, to control costs, insurance companies began to manage the type of care they would pay for. And the most aggressive of these were closed network HMOs, or health maintenance organizations. With such HMOs, the insurance companies would tell patients which hospitals and physicians they could go to. And HMOs usually required patients to go to a primary care provider and obtain insurance company approval before seeing a specialist. And the HMO paid physicians through capitation and risk sharing. So the financial incentive for providers or physicians was to maintain the health of the patient, hence the name health maintenance organizations, rather than just providing more services. And but by the 1990s, HMOs and similar capitated managed care plans had began having success in slowing the growth in health care costs. But they were also unpopular among many patients and health professionals. Specifically, there was a perception that HMOs removed too much control from physicians and patients and placed this control in the hands of insurance companies. And people didn't like that. This quote by federal appeals judge for the Seventh Circuit, Richard Posner, a judge that has a reputation for writing judicial opinions with a bit of wit, really sums up why HMOs were unpopular. This quote is in your textbook, and I'll read it here, but I recommend you read it over a couple times on your own so you really understand what Judge Posner is saying. Many people don't like HMOs because of the restriction on the patient's choice of doctors or because they fear that HMOs skimp on services, since the marginal revenue of a medical procedure to an HMO is zero. From a short-term financial standpoint, which we do not suggest is the only standpoint an HMO is likely to have, the HMO's incentive is to keep you healthy if it can, but if you get very sick and are unlikely to recover to a healthy state involving few medical expenses, to let you die as quickly and as cheaply as possible. And please note, When the court here says that there is no marginal revenue for performing a medical procedure, this is the definition of full capitation. The idea is that the HMO receives a lump sum of money to provide all the care for each patient in its plan. And if the average spending for each patient is below this amount, the HMO makes a profit. And if not, it loses money. And also keep in mind that an HMO would have other incentives than just the short-term financial incentive. For example, if a big company contracts with an HMO to provide health care for its employees for 1 year, and the HMO gets a bad reputation for not providing necessary care, that company may not renew the contract with the HMO next year. Think of if you bought a season pass for a ski resort and the resort only opened for 1 week, even if there was enough snow to be open all winter long. Would anybody buy a pass the next year? Probably not. So by the mid-1990s, there was what is referred to in the health insurance industry as the HMO backlash. And there were numerous anecdotes in the news of people being denied necessary care or having to go to a doctor they didn't like or who was far away from where they lived. And in response to this backlash, many state legislatures reacted by passing laws including patient bills of rights that said that patients had a right to choose their provider, and also any willing provider laws. These any willing provider laws said that a health plan must include in its network any qualified provider who was willing to accept the terms of payment offered by the insurance company. And what this boiled down to was to make closed network HMOs more difficult to create, and it removed the ability of insurance companies to offer volume discounts to providers who agreed to see a large amount of patients covered by an HMO or an insurance plan. In short, it removed some of the cost control tools that insurance companies had developed. And some state boards of medicine even brought disciplinary actions against physicians working for HMOs doing utilization review. So if a physician got a job reviewing insurance claims for an HMO to make sure that they were medically necessary, questions were raised as to whether this was professionally ethical for physicians. And as a result, you began to see a lot of the aggressive cost controls get eliminated. And fully capitated HMOs were increasingly replaced with so-called PPOs, or preferred provider organizations, and other insurance models that focus more on fee-for-service payment. And unsurprisingly, health insurance premiums and costs continued to grow, and at a faster rate. Now here's another slide from the Kaiser Family Foundation that shows what I described in the last slide. Specifically, it really illustrates the growth of managed care generally in the 1990s and the rise and the fall of the HMO over the last few decades. So as you can see in the first row, in 1988, 73% of people got insurance through their employer had a conventional insurance plan. With such a plan, the patient could choose their provider and the insurance company paid the bills without question. And we saw before how much health spending rose in the 1980s. So employers by this point were looking for ways to cut how much health benefits would cost the company. And they turned to HMOs and other forms of managed care. So you can see how HMOs and PPOs really began to take hold beginning in the 1990s. And pay particular attention to 1996 right here. This was kind of the height of HMOs, with nearly 1/3 of people with employer-based insurance plans being enrolled in HMOs. And on the next slide, we'll see how in the late 1990s, this is where the growth in health spending really started to slow down a bit. But with the HMO backlash, they became much less popular and were largely replaced with PPOs. And PPOs are more similar to the conventional insurance in that the providers are primarily paid through fee-for-service reimbursement. So although providers in a PPO agree to some restrictions on how much they can charge, what diagnoses are required for certain treatments to be covered under the plan, and so forth, with a PPO, there continues to be a financial incentive to provide more care. And that's different from an HMO. Okay, so recall that HMOs kind of reached their height in the 1990s. And think about this as you look at this chart. The dark blue line, this one right here, that's squiggling all over the place, the percentage at which health expenditures grow fluctuates with inflation. So even though health spending continued to rise during the 1990s, it looks like it was not growing as fast as in the 1970s because there was not as much inflation in the 80s as in the 70s. So this dark blue line is perhaps a little bit misleading. For this reason, I want you to look at the light blue line, showing what share of the GDP consists of health spending. And specifically, between 1995 and 2000, right in here. This figure right here, this line, it's pretty much flat, and it even goes down a tad. And that's about the only time during the 50 years between 1960 and 2010 that the growth in health spending as a percentage of total GDP stayed flat or dropped. And there are, of course, a number of factors at play here, but one could argue that HMOs and managed care cost controls played a major part in causing the growth in health spending to slow down during that period. And you can see, as more PPOs took hold in the 2000s, the share of GDP consisting of health spending began to grow much more rapidly. So that's the rise and the fall of the HMO and a history of some managed care techniques to control costs. Now let's shift gears and look at this new three-letter acronym, or TLA, the ACO. The term was first coined by Fisher and Hackbarth in an article published in Health Affairs in 2007. And remember, back in 2007, health costs were growing at a very high rate. And you may recognize Dr. Fisher's name from other coursework because he is in charge of the Dartmouth Health Atlas, which tracks health spending variations around the country. Also, this concept of accountable care was discussed in Atul Gawande's influential New Yorker article, The Cost Conundrum, which we've already quoted from. And in the debate over health reform that led to the enactment of the Affordable Care Act in 2010, President Obama made all of his staff members working on health care read this article. So it's considered a very influential article on the topic of healthcare costs. And in it, Dr. Gawande says, the lesson of communities in the U.S. that have been effective in providing high-quality, low-cost care is that someone has to be accountable for the totality of care. So at a conceptual level, ACOs are organizations of providers that can be held accountable for both the cost and quality of the full spectrum of a population of patients' care. And there are a variety of different potential ways that ACOs can be structured, but the common theme is that they are structured around healthcare providers, hospitals, physicians, other health professionals, rather than insurance companies, which ran the show with HMOs. Beyond focusing on having healthcare providers as the anchors, the idea with ACOs is that a number of different models could be used to create one. On the one hand, you may have highly integrated organizations where all of the hospitals and practices are owned by the same entity, and individual professionals are all salaried employees. And then on the other hand of the spectrum, you may have so-called independent practice associations, or IPAs, or even virtual networks. And with these, providers that make part of the ACO are separately owned and independent practices. They have their own practices, but they may form a joint venture to create a network just for the purposes of the ACO. And to achieve accountability for the cost and quality of care, there are financial incentives tied to both lowering the costs and achieving high quality. And the metrics used to measure quality include things like patient preferences and patient satisfaction. So you want to avoid the situation where patients feel like they're forced to go to a doctor that they don't like, or that they don't have access to specialists and they're unsatisfied with their care. So with this background on ACOs and managed care, let's consider how they compare with a pure fee-for-service payments model and purely capitated HMOs. We will cover some of these concepts in greater depth in the next presentation as well. Regarding payment, obviously fee-for-service entails payment per individual procedure or service. With a fully capitated HMO, there would be no payment for specific procedures or services. And with ACOs, the idea is that there could be some sort of hybrid. The providers may still get fee-for-service payment for each procedure, but they get a share of the savings below a benchmark generated for providing efficient care. So the ACO has an incentive to keep their spending below the benchmark amount. In terms of financial incentives, in a fee-for-service, the incentive is to increase utilization. The more you do, the more you get paid. With HMOs, it's the opposite. As Judge Posner said, the incentive is to minimize utilization. And then with ACOs, again, it kind of falls in the middle with efficient delivery, what I'm calling efficient delivery. If providers perform a lot of unnecessary procedures, they won't get as much of a shared savings bonus. But if the ACO does not provide good care, it may not achieve its quality measures, and so there's a counterbalance to the incentive just to cut costs. Regarding quality, I think that under fee-for-service, there is only indirect quality assurance. We've talked about medical malpractice liability and the incentive it may create for providers to exercise good care. But we've discussed how it really doesn't do that good of a job of achieving this objective. And physicians may face disciplinary action from the Board of Medicine for providing substandard care, but the culture of healthcare providers is not very open about discussing errors. Additionally, with fee-for-service, there is an incentive to provide unnecessary care. And anytime you're cutting into a patient, exposing them to radiation, really doing any procedure, there is always a risk of harm, even if that procedure is done properly. And that's a problem if you're providing procedures or care that is ultimately unnecessary. Similarly, for HMOs, I think the quality assurance is only indirect. If the quality is really bad, the HMO will lose its customers. Additionally, capitation means that if the HMO has to provide follow-up care due to errors, that the HMO will eat its profits. But unlike ACOs, there's not anything directly tied to achieving quality standards. With ACOs, there are specific quality standards that must be achieved, and we'll discuss those further in the next presentations. In terms of provider choice, under a pure fee-for-service or traditional conventional insurance model, the patient could go directly to the specialist that he or she wants to see, In terms of provider choice, under a pure fee-for-service or traditional insurance model, the patient can choose his or her physician. The physician charges what he or she wants, and the insurance company will pay it. So there is a lot of choice. With HMOs, there would be closed networks. And the patient would have to go to one of those providers within the HMO network. With ACOs, it is theoretically open like with fee-for-service. A patient is free to choose which physician he or she will go to. However, as we'll talk about it a bit later, the ACO model may encourage providers to consolidate into integrated delivery systems. So in some communities, a patient may have a hard time finding a physician that is not part of the ACO. Finally, regarding access to specialists. In the fee-for-service model, the patient could go directly to the specialist that he or she wants to go to. With HMOs, there would likely be some gatekeeping, requiring a referral from a primary care physician in order to see a specialist. And with an ACO, there would not be specific gatekeeping, but the ACO has an incentive to try to reduce unnecessary services by specialists. So the ACO would try to implement something like the patient-centered medical home, or PCMH, to make the primary care physician the quarterback of care and the natural first stop in addressing a problem. In other words, a good ACO would make it really easy to see a primary care physician to receive preventative and less invasive care by offering things like same-day appointments, later office hours, and then you'd go to a specialist only if it's really necessary. Again, we'll talk more about this in the next presentations. But that's a basic overview of the history of managed care, some of the issues with high health spending in the United States, and ACOs at a conceptual level. Thank you.